So I'll be talking about muscle-invasive bladder cancer and kind of the standards of care around that, which in contrast to maybe some of the other topics we've recently heard about, it hasn't changed a lot recently. The data that we're going off of really is almost 20 years old now that demonstrates that neoadjuvant chemotherapy with cisplatin-based chemotherapy should be offered to all patients that are undergoing cystectomy. And so some of the important issues with it are that we don't do a very good job as a profession, especially urologists I think are highly to blame for that we don't do as much neoadjuvant chemotherapy as we should be doing. It's getting better, but we still have a ways to go there. Other issues are that neoadjuvant chemotherapy isn't tolerated by everybody, especially for bladder cancer patients. We run into a lot of issues with patients with renal insufficiency, and so then they're not cisplatin candidates. And so one of the clear messages I want to get across that we run into not uncommonly is in the community are patients that aren't qualifying for cisplatin chemotherapy and then they end up getting carboplatin. And we know that that's a much inferior approach, and so I want to strongly convey that message. And then kind of the last couple things are that we're very hopeful about getting new markers that will help us identify who is going to benefit from neoadjuvant chemotherapy. The benefit is relatively small to modest, that is 5% survival benefit at 5 years. And so if we could identify patients who are less likely to benefit from that and can move on to timely cystectomy, that would be highly beneficial, and then really push hard on the patients that we know are going to benefit.